Good morning, everyone. Welcome. We will get started in just a minute. We're letting everyone in to the webinar. We appreciate you joining us this morning. So if you can give us just a minute or two, we will go ahead and get started. Yeah, we really appreciate you being here with us this morning. Lots of great information, we'll definitely have some time for Q&A at the end of the presentation, and we'll go from there. So thanks again, everyone, for being here. We'll get started in just a minute. Good morning, everyone. Thank you so much for being here and joining us for this very important conversation. We really appreciate you taking the time to be here. In the interest of time, I know there's a lot to talk about, so we are going to go ahead and get started. Again, thank you so much for being here and welcome to our COVID-19 vaccination forum. My name is Paz Oliveras. My pronouns are she, her, and Aya, and I serve as the Vice President for Student Affairs here at CSUSB. Thank you again for joining us for this important opportunity to learn about the current status of COVID-19 in our communities and to share more information, reliable information, science-based information about the vaccination. Here to present and answer questions today is Dr. Michael Sequeira, who serves as the Public Health Officer for San Bernardino County Department of Public Health. We're also joined by campus leaders who will participate in the question and answer portion of the program, along with Dr. Sequeira, including our Vice President, Sam Sudhakar and Julie Lappin from our cabinet, as well as a number of members of our Repopulation Task Force, Jenny Sorensen, Lenise Warren, Bob Tensar, Jean Durr, Beth Jaworski, and Gerard Awe. Thank you all so much for being here and available to answer questions at the end of today's presentation. Now, before I turn it over to Dr. Sequeira, I would like to share a few highlights of his distinguished career. Dr. Sequeira received his medical doctorate from the University of California, San Diego School of Medicine and completed his residency in internal medicine and emergency medicine at the University of Oregon Health Sciences Center in Portland. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 hospital emergency departments, including hospitals in San Bernardino, Apple Valley, Colton, and Redlands. As a dedicated medical professional in the Inland Empire, he joined the San Bernardino County Department of Public Health in 2020. Please join me in welcoming Dr. Michael Sequeira.
Thank you, Dr. Oliveras. I appreciate your giving the opportunity to speak to all of you, and I'm here to present to you and wish you well and as you open up in the university. So, what I'd like to do today, I'm going to share now, is present to you an update of basically the story behind the COVID vaccine, the safeguards and the safety record, and where we are with COVID and the vaccine. And also, we're going to hopefully debunk some of the myths and misinformation that's accompanied all of this as well. The bottom line and what I hope comes through, and this is an extraordinarily safe and effective vaccine that's cheap and convenient for an extraordinarily dangerous pandemic. So I want to bring you through all this and hopefully infer in all of you a sense of confidence about the vaccine and about the direction that we have to take to get through this pandemic, and also for you to basically get through your education and in a good and safe way. So. Well, I want to start out with the timeline about COVID and the vaccine. It was in late December, about December 21st, when the Wuhan scientists and physicians discovered this mysterious new pneumonia. On December 31st, the World Health Organization issued its first report about this. And there were dozens, literally less than 100 cases in China at the time. By January 11th, China reported its first novel coronavirus death. This is in 2020 now. That same day that as China reported the first death, they published the complete DNA sequence of this virus. if you look at the reports, it basically in 2.5 weeks from the discovery of this novel virus, we had the complete genetic sequence isolated. By January 12th, after the Chinese scientists published the completed DNA sequence, 20 vaccine groups started working on the vaccine for this new novel coronavirus. The first two were Pfizer and Moderna, and they continue to lead in terms of production and study of this vaccine. By February 10th, 2020, the first vaccine candidates were designed and manufactured, and the stockpiling was begun. And by March 16th, the first two vaccines, the Pfizer and Moderna, entered their phase 1 trials. So it's an extraordinarily, to me, awesome illustration of the power of the immunobiologic scientists within our world, the world community, the world scientific community. It's just an amazing task. What I wanted to do is then talk to you about what's happened to us, and then what we'll do is go through where the vaccine has happened as well. So this is when the virus really seemed to come in June, July, and we all know about the peak in December and January, and you can see that we're reaching another growth peak just now, beginning probably in June. So within San Bernardino County, we currently have had 316,000 cases, and our average case rate is 26 out of 100,000, and it's rising, and largely due to the Delta virus, the Delta variant at this time. Basically, when we look at the rate of anaphylaxis, it's extremely low. Only basically 50 or 5 cases per million doses and 2.8 per million doses, compared to 320 cases per million doses of penicillin. So why the urgency of why we're having to deal with this? And a big part of that is the variants that are occurring. So I want to back up just a little with regard to the development of the vaccine. You know, the vaccine was every vaccine goes through 3 phases of development and approval. The phase 1 is where only about 100 to 200 patients are selected, and it's to look for gross adverse events. Phase 2 is where it reaches into the 100 to 200,000 population in terms of people tested. Again, expanding the look towards the safety and efficacy, and stage 3 is basically expanded further out. None of these stages was shortened or in the development of any of these vaccines. One of the reasons we were able to move through so quickly was that the number of patients that we had on which to test basically were so great that we reached the numbers really quickly, and were able to test and verify the safety of the vaccine extremely quickly. The process was the same, phase 1, 2, and 3, and the process 2 to reach emergency use authorization was the same. The American College of Immune Practice basically reviewed all the data and then submitted it to the FDA, which then passed down to each of the states, and in our case, California Department of Public Health, which has its own scientific committee with its own immunobiologist from Stanford, UCLA, and UCSF, and many of the other universities. And so each panel reviews safety and efficacy before it's actually passed on in terms of the safety. So, the amount of vaccine that has been given, it's basically up to 50 billion cases in the world today, and 260 million just in the U.S. And with an extraordinary safety record. There are very few side effects, and the few side effects that we've seen have been very rare compared to the overall incidence. So the variants have been coming upon us, though, and I'm going to talk a little bit more about the Delta variant. And there's an important principle here: is that the faster the virus grows, the more the replication, the more the chances of an error. And we liken this to the fact that if you do any task, whether it's let me just pick to bake a cake. If you had the whole day to bake a cake, you basically would make a pretty mistake-free cake. But if I were to ask you to bake a cake every 5 minutes or every 15 minutes, most likely you'd be making some errors and it'd be kind of sloppy after a while. And that's very much kind of the same kind of basis or principle for the variant development. The faster a virus has to grow or is growing, the more the chance for a variant. And there's natural selection, of course, as well, because as the virus growth and spread will go into the direction of least resistance. So it's going to spread to, for instance, in this case, the unvaccinated population, and it's going to grow and spread. And depending on its ability to spread, it's also going to go into the vaccinated population as well. And so, and we do know that society's opening up. We have to open up. It's a social, it's an economic, it's an educational imperative, and we have to open up. We've got the tools to be able to open up safely, and that's another reason for why there's an urgency here to talk about this and to talk about vaccination and getting everyone opened up safely. I want to show you some of the data that we have with regard to the variant. These are all the variants that we had isolated, and you can see in the last weeks, 84% of our variants were Delta, and actually even more recently, it's over 92%. And you can see this is actually a more graphic illustration of all of our variants. Across the top is the B117 or Alpha, which is the British variant, and right here is the Delta, the B1617. And you can see that even as of February, there were 0 Delta variants. And if you go through to July now, by far the dominant variant here, 1,235 out of 1,400 were Delta. So the Delta clearly has a competitive advantage, and it's basically affecting and infecting almost every unvaccinated person that it encounters with over 100% more infectiveness or transmissibility than the original virus, and even more, 50% more than the first variant, which is that British variant. So this Delta variant, let me talk a little bit more about that as well. It's highly infectious. It's 100% more infectious than the original virus. It does seem to be affecting the younger population, ages 16 to 49. So it's this is partially a statistical aberration because we have most of the older population vaccinated. So the people that are vulnerable, the unvaccinated, are the younger population, and so the infection is definitely hitting the younger population. And just because this is the spectrum of disease, we're seeing more hospitalizations and more deaths. But the actual case fatality rate for the virus is low, seems to be as low as the original, and maybe even slightly lower. The virus actually produces high viral loads, amount of virus uh, 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 that's actually in the nose, and that translates when you're doing PCR tests to low CT values. You'll see that CT that term about PCR tests. But and so what happens is this Delta virus tends to infect, especially the unvaccinated, but even the vaccinated. And you'll see that the vaccinated people, about 10% of our cases are in vaccinated people, but they don't get hospitalized and they don't get sick. There's basically only a 1 to 3% hospitalization and death rate in the vaccinated patients with the Delta virus. There's a shorter incubation period and a significantly longer shedding time as well. And the thing is that vaccinated patients also get colonized with this. The virus actually infects the nose, but it's a different type of immunity just locally in the nose compared to what produces sickness, what allows the virus to actually spread through the body and cause systemic illness like the pneumonia, like the effects on the brain and heart. So the vaccine actually stimulates that immunity through the T cells and through the B cells, which produce the antibodies, so that the people who actually are vaccinated can get colonization, can actually shed the virus, but they don't get nearly as sick. And all of our data within San Bernardino County supports this as well. And that's what this sixth point: vaccinated patients, about 10 to 15% of those are infected, and much lower hospitalization rates, and much lower death rates as well. So it's the Delta variant is there. We just even as of a few days ago, the New England Journal of Medicine produced a study to show the effectiveness of the COVID vaccines, against the Delta variant. And what's important there is that it actually underlies or underlines the need and effectiveness of that second dose. People who don't have their second dose of the Pfizer and Moderna are still only incompletely protected. So it really again emphasizes that the importance of being fully vaccinated. So I wanted to go back and show you where we are within San Bernardino County. We're close to basically 58% of any vaccination, and with we are now at 50% fully vaccinated with over 1 million doses given, and this gives you the U.S. and international number of vaccinations provided. We're at this time really interested in pursuing the effect of COVID and also the vaccination of our particularly vulnerable populations. And we've done, we've worked with ESRI. I used to know it as ESRI, but in developing geomapping of our county within particularly vulnerable zip codes here, and you can see. And when we look at social vulnerability, we look at the first quartile of the Healthy Places Index, and this is the distribution of quartile 1 within our county. This is a cumulative index of social economic status, basically status in terms of condition. And this is the eligible residents that we have within quartile 1, 2, 3, and 4. And this is our county and where each of our zip codes are with regard to quartile 1, 2. 2 is the salmon, 3 is the light blue, and 4 the dark blue. So, and what we're doing, we're further targeting specific zip codes with high vaccine equity metrics. that have the lowest healthy places index quartile. So I just throw this up to show you the areas that we're really focusing our vaccination efforts on. And it's these areas with the first quartile that actually have the three to four times the incidence of COVID and 3 to 4 times the morbidity and mortality without the vaccine. So that shows and emphasizes the importance of vaccine, of actually equity and vaccine equity in terms of getting our population vaccinated. So we've actually looked at pushing now. We've got the low hanging fruit with regard to the vaccine, and we're now into our Operation Next 100,000, and it involves basically a combination of strategic pop-up vaccine locations. We're looking very specifically at messaging, the safety of the vaccine and the necessity of it. And we're working with our community-based organizations. That's what CBO is, and we have a collaborative of our community-based organizations with regard to faith-based and community-based, and working in getting the message across, as well as getting the vaccine to all of our quartiles. And we're also working on a public information network as well. And we have a collaborative partnership with the CDPH on vaccine tele outreach as well. So these are our county-run vaccine sites, and we do have a vaccine site at Cal State as well, and it's important to remember and to compliment Beth and Lenice on getting that together. Where this slide is basically to show you how aggressive that we've been pushing this to get mobile clinics and specialty teams. We have homeless teams, homebound teams, special events we're trying to target fairs and firemen, strategic locations, churches, equity areas, our schools, and our skilled nursing facilities as well. And this is the feedback loop that we're basically trying to keep going with regard to addressing those people who have vaccine hesitancy. A big portion, and you've probably seen this, Dr. Vivek Murthy, our current Surgeon General, basically came out with the declaration that COVID-19 misinformation is an urgent threat to the United States population. And because of this misinformation, we've seen with every Facebook issue that's falsely feeding COVID-19 misinformation, it produces a significant incremental increase in the hesitation to actually take the vaccine. So Dr. Murthy basically declared this vaccine misinformation as a public health hazard in and of itself. The president actually accused social media platforms of killing people with the spread of COVID. And Dr. Fauci actually says the US probably would still have polio if there had been as much misinformation about the polio vaccine as we have about the COVID vaccines now. So this is a serious issue that we're battling, and we basically want to be able to address specific things like this. These were actual Facebook entries. Specifically, it says, "Don't stay in. The faster this spreads, the sooner we can get past the worst of it and return to normal." And Facebook actually accepted this ad. And another fact check was not done. This basically down here it says, "Hospitals on lockdown as first COVID vaccine patients start eating other patients." Literally, I mean, seriously, this was actually allowed on Facebook. And we see this all the time. COVID is a scam, and just not true. Fortunately, we were able to put enough pressure on at least Facebook and Instagram, and more so on Twitter. With this whole campaign that's together against COVID-19 misinformation, and ideally, it encourages people to check the source, check how it makes you feel. False news can manipulate your feelings for clicks, and then check the context. Look at the public health authorities, like us to confirm the content. So it's really important that you realize that there's a lot of misinformation out there, and we're here to actually answer those. With that, I don't know whether there's anything in the chat that has actually come up yet, but I'm going to go through some of the myths that we've seen.
We do have some questions, but I think go ahead and I think keep going, and then we'll get to the questions at the end. And just to make a really quick point that those folks, I know that there are questions that have come in. Some of them we haven't responded to yet because we want to pose them to Dr. Cicada at the end. Others have been answered. So if folks go back to the Q&A box and just look up the answered pieces, many of your questions have been answered that are very campus specific questions. Thank you. Go ahead, Dr. Cicada.
Okay, Dr. Horowitz. Okay, this myth, I've already had the COVID vaccine and I've recovered, so I don't need to get a vaccine when it's available, do I? So basically, we're getting more and more information about what we call seroprevalence. And it is true that previous COVID infections actually do confer some type of immunity. The difficulty, though, is that when you've had COVID previously, it produces a significantly inconsistent immunity, and we now know that immunity from prior COVID infection, the immunity that you get from that is imperfect, and the infection rate is significantly higher in people who've had COVID-related immunity compared to the vaccine, and that's probably anywhere from about 30 to 50% more antibodies and immunity with the vaccine. So it's difficult to predict who actually is more immune once they've actually had the infection. And drawing antibody levels are not accurate because there's another type of immunity, the T cell immunity, which is much more important with regard to fighting viruses. Basically, another myth, there are severe side effects of the COVID vaccines. What we've got to do is look at the short-term and long-term side effects. It's true that up to 80–85% of people who get the shot get a sore arm, and actually up to 70–80% of people get a low-grade fever, even a higher fever, as well as kind of malaise or not having a lot of energy and kind of achiness and headaches. That does occur. That the internet especially is full of basically the people telling their stories about this. But the important thing is these are all short-term side effects. They're self-limiting. They basically go away and they're treatable. You can take aspirin and ibuprofen and Tylenol for the fever and achiness, and they're gone after 2–3 days. And then you're protected. And there's a huge amount of reassurance and confidence that you get from that. So in terms of the other side effects, we've heard about anaphylaxis, and I've told you the difference between and the safety profile of all the vaccines on anaphylaxis. We've heard about the blood clotting of the Janssen vaccine, and we've isolated it usually to women in the 20 to 49 age group. But the incidence of these clots are actually as low as the general incidence without the vaccine in the same age group. It's just that they're more clumped and they form an epidemiologic pattern, and that's why we've called it an incidence. We've heard about the evidence of myocarditis or heart inflammation in younger men, especially from our mRNA vaccines. But the incidence, again, is about the same, and virtually 100%. Actually, nothing's 100%, I've been taught, but 90–95, by far the vast majority of all of this is self-limiting and doesn't require any treatment at all. And so there are these side effects. There's Guillain-Barré, and I'm going to cite you back to almost every vaccine: the flu vaccine, the polio vaccine, the tetanus shot. All of these vaccines can have a Guillain-Barré come and ensue. It's just an autoimmune reaction that cross-reacts to the antibodies produced by the vaccine. And the incidence of Guillain-Barré with these vaccines is actually significantly lower than the incidence after a flu vaccine. So basically, again, what I said at the beginning, these vaccines are extraordinarily safe and effective. So here's another myth: I don't need to wear a mask after I get vaccinated to COVID-19, and this is important as you go, basically go to more consistent congregate settings like school, et cetera. And there is some degree of protection with the mask, and it certainly helps to prevent droplet nuclei propagation when someone coughs or sneezes or sings or talks. So there is that protection, and we're finding even with vaccinated patients that there is localized infection in the nose and mouth. So that's why basically we've said, even if you're vaccinated, when you're indoors, you really need to wear a mask, and it's we have to control this. So here's another myth: more people will die as a result of a negative side effect of COVID vaccine than would actually die from the virus. And I think our extensive experience over the past year and a quarter has shown that that's absolutely not true. I mean, with almost 50 billion vaccines given in worldwide and 350 million in the U.S. Compared to the mortality and morbidity of COVID, and not to even mention the effects of long COVID, which is much worse than mono. Mono can make you sick and feel out of it for a few months. The long COVID can go up to 6, 8, 9 months. Not to mention the effect on the brain and kidney and heart that the COVID can actually confer. So certainly the deaths or mortality directly attributable to these vaccines is minimal, is very, very low. So, okay, here's another one. And the scientists and immunobiologists can easily answer this, but COVID vaccines will alter my DNA. So the first thing is both vaccines, the mRNA and the adenovirus, specifically the Pfizer Moderna's, are small pieces of messenger RNA. They're actually isolated, coated with a lipid layer and injected, and they're injected into the muscle cells, and they teach the muscle cells how to produce that spike protein. And after 18 hours, that piece of my messenger RNA is destroyed. It doesn't stay in your body. It's destroyed and it's eliminated. So it's just during that 18 to 24 hours, it teaches the muscle cells to produce this spike protein, and the body recognizes it as a foreign protein, and therefore then produces the antibody and stimulates the T killer cells and the T memory cells that induces your immune response. So the vaccines do not get into your DNA, and it's from a molecular standpoint, it's impossible. So it doesn't alter your DNA. So here's another one. COVID vaccines cause infertility or miscarriage, and we were all worried about new things, but basically, again, the experience that we've had over a year, in as many vaccines as we have seen, there's been no evidence to support the infertility. There's been no evidence to support a preterm delivery of pregnancies, and in fact, the evidence is pretty significant and scary with regard to COVID infection in pregnant women. the incidence of preterm delivery and premature infants is 5 to 10 times greater in COVID infected mothers. And remember that the pregnant state is a relatively immune vulnerable state. So it's really important to know. And when you think about a miscarriage, you really have to, you definitely don't have to fear the vaccine. You have to fear the virus. So it's the vaccines do not cause infertility, and there's been no evidence to show increased miscarriages with the vaccine as well. So let's go on to the next myth. So I'm allergic to eggs, so I shouldn't get the COVID vaccine. So neither, especially the Pfizer and the Moderna vaccines contain egg, and eggs were not used in the production of any of these vaccines. And old vaccines were created in vats, and eggs were basically were a matrix to develop and grow the virus, which then would produce the vaccine. So that's not the case with these vaccines. And so egg allergy, if you have an egg allergy, you shouldn't have to worry at all about receiving this vaccine. So myth number 9, COVID vaccines must be stored at extremely low temperatures because of preservatives in the vaccines. We've actually found that the Pfizer one basically requires ultra low temperature storage, and we've been able to extend that. But it's not because of the fact that there are preservatives. There are no preservatives in either of these vaccines. So there's if you're concerned about preservatives because of the ultra low temperature, that's not the reason. So it's just the pieces of messenger RNA molecules are just very sensitive to temperature. So basically, here's how to sign up. Cal State has its own campus website for campus vaccines, and this is it: www.csusb.edu/COVID-19, and you can actually sign up for MyTurn for any of the vaccines, as well as call any of your CVS, Walgreens, Rite Aid pharmacies as well. So I'm going to leave it at that. And if there are any further questions, we can definitely open it up at this time.
Wonderful. Thank you so much, Dr. Sequeira, for all that wonderful information. So we have a number of questions. I know that the team has been doing their best to try to respond to as many as possible that are campus specific, but I'm going to try to go through the ones that are more kind of general, and try to get through some of those ones, because I think you may be able to answer some of these. Let's see. Sorry. So a question, there's been a couple questions in here about giving the vaccination to folks who are of different ages, children, 13 years old. So the question is it really safe to give a 13-year-old the vaccination? And the person is asking because they've got a child that's going to school now, back to school. So they're asking that question about just the age and what impact that might have on the vaccination.
Yeah, if it's approved, it's very safe. Again, I went through the phases of proof of safety through the FDA process, and it's been Pfizer has been approved all the way down to age 12, and that means it's been shown in hundreds of thousands and now millions of people 12 and over. So what we've seen with the younger population, they tend to faint more, and it's just because it's more of a shot than anything. And we've seen a little bit of this inflammation of the heart that I had mentioned before, but by and large, the safety profile has been extremely good for a 13-year-old. We're really waiting because we really would like the FDA to approve ages down to age 6, because that's again particularly they're all unvaccinated, and we're opening up our schools. So yes, you can feel confident in this in the safety of all the way down to age 12. So.
Great, thank you. So I have another question here. So it's kind of a longer question, but I'm going to try to get through it so that you can try to provide us with a response. It says, as of July 16th, there's been 10,991 deaths, 48,385 injuries, and 463,457 reports of adverse events from all age groups from the CDC's VAERS website. Keep in mind, only 1% of vaccine injuries are reported by VAERS. This is more vaccine injuries than any other vaccine to date. With this data, why should I get this injection as opposed to taking ivermectin, staying on top of my natural immunity, or taking my vital minerals daily?
First off, no vaccine has actually gone through the amount of recording of adverse events, so that and no vaccine has been given as many in as short a time. So you really have to look at the denominator if you really want to statistically look at this. So it's true that it's high, but you have to look at the denominator to really look at your statistical importance. And if you really want to do a statistical analysis, it more than easily proves to be extremely safe. Ivermectin, we have a few scattered studies compared to the 350 million cases of vaccinations being given. We have 3 scattered studies that are not randomized, not controlled, and they're basically anecdotal. So if you really have to apply an equally true and unfair scientific eye when you look at data. So look at the data for ivermectin and look at the data for the true data and your denominators for the vaccine, and you'll see there's a lot more documentation for the vaccines.
Thank you. I appreciate that. Let's see. So the question is, and this may be to the campus or just in general, but I think it applies either way. The question is herd immunity possible? What percentage of the population needs to be vaccinated before that can occur?
Well, the herd immunity is possible, and we've achieved it, right, with smallpox, and we've achieved it with a number of other viruses, and it actually deals with the infectiousness of the virus, and it's what we call the R naught. How many people actually one person will spread the infection to, and so when and there's a formula, one minus the R naught over 100, but and it basically gives you the percentage of vaccine or people that we need to vaccinate to give us herd immunity. The problem is that the Delta the Delta virus has created, it's so transmissible, it's basically changed the equation multiple times. What we thought was 70 to 75% was necessary. It's probably pushed us into 85%. And remember too that we can have a combination of seroprevalence of people who've been vaccinated and who have the more inconsistent immunity from previous infections. So it's possible, but it's getting more and more difficult, especially as our unvaccinated people are allowing the spread and growth of the virus. So.
Thank you. So I think actually these next couple of questions are maybe sort of related. So I'm going to kind of ask them together. It says there's talk of booster shots. Should vaccinated people be worried that their protection from COVID-19 is decreasing over time? And the next question is kind of related. It says, I got the vaccination in the spring and was wondering how long the vaccine lasts. So I think it's really just a kind of about the timing of the vaccine and the protection.
Yeah, and I think those are great questions, and we all have to ask that, and we're constantly worried about that. Those of you who follow the news, we've actually the FDA has just released a third shot boost for people who have immune compromise. Those people have had organ transplants, who are taking immunosuppressant drugs, who have cancer or other drugs of immunosuppression like long-term prednisone. So what we did was we found that people who have those immune compromised diseases are vulnerable to the new infection, even with two shots vaccination, and then a third boost actually pushed them into the safe range. And what we're learning at this point, and we're, at some point as Delta, and hopefully it's the last variant, but we're watching for any other variants as it progresses. And the time from the original vaccination progresses, the antibody and T cell counts, and most likely, like tetanus, will wane. So we'll most likely need a boost, and we're watching it very closely with regard to when, and it may come sooner rather than later. But right now, it's there for immune compromised patients. So.
Okay. So I appreciate you sharing that, because I think that's something that folks have been talking about more and more. Should I go and make an appointment for my third, or for my booster shot? So your advice is what, based on that?
Wait,
Okay.
unless you have immune compromised problems.
Okay. So for immunocompromised folks, that's probably a good idea.
Yeah, the cool thing is we've got enough vaccine now. We wish we didn't have enough vaccine, because we want everyone to come and get vaccinated, but we've got enough. So and we're actually the government and the vaccine manufacturers are stockpiling this. And the other really amazing thing about the way messenger RNA vaccines are developed, if we have a really significant variant develop, the vaccine development companies can just take the DNA from that and develop messenger RNA that is very specific to any new variant, and we'll be able to produce a boost almost overnight, and be able, and then it's production time more than anything. So we're really we're armed to be able to take care of this. We need the people to all pull together and get the vaccine, so we don't have another variant like the Delta. So.
Great, thank you. So, we've had a few questions that came in, and I'm going to try to summarize them or synthesize them a little bit, specifically around the FDA approval for the vaccine. And so I think the question is, why hasn't it been approved yet? And then also, should we, like, if I'm a person who's not yet vaccinated, should I be waiting, or, to get approved? And if not, why not? So maybe you can talk a little bit about that.
Yeah, and actually, the safety profile has clear. FDA approval is really it's multifactorial, and it incorporates a lot of things. With regard to safety, the FDA looks at the percentage or safety of adverse events, and then for how long. And usually they're like 6 months of data. And so that let me just tell you that the safety data for full FDA approval is there. What they're at this point, we're trying to work out are all those little details, like, geez, is it safe when we release it to the mom and pop pharmacy, and how are we going to enforce that it's going to be kept at the right temperature, in those type of small things. So the FDA now realizes that the public health has pushed them. I said, we need full approval, and so they've actually, based on safety profile, what we're hearing is by the end of this month, we should have full FDA approval. There's nothing yet that has come up to prevent the FDA from not giving full approval. It's just ironing out all these small details, and again, by the end of August, what we're hearing is that the FDA will give its full approval.
Okay, so you think or at least from what you all are hearing, it's coming soon?
Yes.
Okay, thank you. And then, I don't know kind of how much you want to say about this, but this is, kind of an interesting question, and I don't know what the answer to this might be. But the question is, would you or could you summarize the pros and cons of each type of vaccine? Like, I'm assuming COVID vaccine. Which one is preferred? and or the safest based on the medical research and why. So I don't know if they're equally safe or what, what your response to that would be.
Sure. First, all of the vaccines are effective. There's two that are what we call the messenger RNA vaccines, and those are the Pfizer's and those are the Moderna's. And they're almost twins. I liken them as twins. And Pfizer started first, so they've actually got the most patients earliest. So when they started quickly and got people down to age 18 and then down to age 12. So that's why Pfizer has been approved for down to age 12 and not Moderna, just because they started first. They have the most patients. Moderna is coming right behind them, and there really hasn't been any kind of distinction between those two. So Pfizer's requires that ultra low temperature, but they've actually come out with the fact that it doesn't have to be. It can be at standard freezer temperatures for up to 30 days. So that's much less of a concern as opposed to the Moderna, which can be kept at regular freezer temperatures. So you're going to find Moderna a little bit more common and a little bit more easily found at standard pharmacies, just because it's a little easier to store. The messenger RNAs had been linked to that the myocarditis or the inflammation of the heart. That's really the only thing that we've seen with them, and it's so rare that it's not really a significant adverse event. And the American College of Pediatrics has continued to recommend in that age group. There's the third vaccine is the Johnson & Johnson or the Janssen, Janssen vaccine. That's actually developed with an adenovirus vector. It's a cold virus that basically they made replication incompetent. It can't reproduce in the body. And the advantage of the Johnson & Johnson is it doesn't require significant freezing time, and it just takes one dose. And the other thing is it confers very good immunity. The Johnson & Johnson was linked to that clotting disorder that we've seen, and if we see it, and it's still exceedingly rare. If we see it, it's in younger women from ages 20 to 49. So even in that age group, it's exceedingly rare, and it's very treatable. The blood clots and the blood clots go away. It doesn't produce a permanent coagulated state. So those are the three. They produce the same kind of immunity because basically they teach the muscle cells on how to produce that spike protein, which then produces the antibody and the T cell resistance to it. So.
Great, thank you so much for that. I appreciate that. Hopefully that's helpful. There were definitely a few questions about the differences between the vaccines. So I think that was really, really helpful information. Before we go on with more questions for you, Dr. Skate, I did want to just draw people's attention to the chat. There have been a few different questions related to the Daily Health Screen. So there is a response to, I think, a key question that a few different folks have asked. I want to just make sure folks see that response. And then I wanted to go ahead and pose the next question. So the question is, why are people that are producing natural antibodies from a previous infection required to get the vaccine? And so then there's kind of a follow-up piece to that. There are many studies noting that the effectiveness of natural antibodies. This is just one example. Months after recovering from mild cases of COVID-19, people still have immune cells in their body pumping out antibodies against the virus that causes COVID-19, according to a study from researchers at Washington University School of Medicine in St. Louis. Such cells could persist for a lifetime, churning out antibodies all the while. So I guess the question, again, back to the beginning, is sort of why would a person who's producing natural antibodies from a previous infection still, why would it still be smart for them to get the vaccine?
Okay. Again, this is I went through it as in the myths, and we can talk about it some more. It's true that you can get immunity from a viral infection, which from catching it. If you survive it, you survived it because you produced antibodies and T cells against that virus. The problem is we're talking about a virus that basically is a threat to almost every body in society, so that the degree of consistency of that immunity is extremely variable, and you can't you can't even measure resistance to a viral infection from measuring antibodies. It's well known that it's the T cells that actually produce the significant immunity to cancer and to virus. So antibody studies are very non-predictive of the degree of immunity, and we've seen and there are direct studies that actually look at the degree of immunity, looking at T cells, antibodies, and total incidence of case incidence of infection, hospitalization, and death. And the people basically who have had COVID have a significantly higher incidence of COVID infection, hospitalizations, and death compared to those vaccinated. So the evidence is there. I'm aware of that University of Washington study, and it doesn't take into consideration subsequent comparative studies between vaccinated states, especially the completely vaccinated states and prior immunity. Well, we appreciate it that if you caught the vaccine and you're immune. That's much better than if you've never had it and you're completely vulnerable. But what we're trying to do is prevent propagation of this. So if you're inconsistently immune and you get the Delta, you're going to spread it, and you're going to, just like vaccinated patients, but and there's a chance that you're going to get significantly sicker too. So because of that, we're trying to control this in society. We're recommending everyone get vaccinated.
Great, thank you. So here's another question that I think is an interesting one. It says, if you got the Johnson & Johnson vaccine and are worried about complications such as blood clots, should I get the Pfizer vaccine to be safe, or would that just add more complications?
Yeah, the vaccines aren't additive in terms of their effect on the coagulation system, on causing blood clots. So I don't understand the question. Is this person contemplating whether or not to get the Johnson & Johnson versus the?
I think they got the Johnson & Johnson. It sounds like they already got the Johnson & Johnson, and they're, I guess, worried about the potential side effects of blood clots. And so they're wondering, could it be, it sounds like they're saying, could it be prevented by taking the Pfizer? But I think what you're saying is that's not how it works. But go ahead and put it in more scientific terms.
And if you've gone more than 18 days after your Johnson & Johnson, the blood clot risk is gone. And there's no blood clot risk from the other two vaccines. There are studies out now for crossover vaccines, those who've had the messenger RNA, the Pfizer, Moderna, getting a Johnson & Johnson, and also the people who've had the Johnson & Johnson getting the messenger RNA. So those studies are coming out, and so that it kind of makes sense that if you want to try it, but there's no, again, we can't completely condone it because we don't have the randomized controlled phase 1, 2, 3 studies yet on those. So.
Thank you. So this question came in a couple of different ways. So I'm going to go ahead and put it out there. I think you might have hit on it in your midst, but I'm going to put it out there anyway, since a few people asked sort of similar questions. Do the COVID-19 vaccines contain aborted fetal cells?
No, they don't. And, if you think about a cell, the cells are big, and these are just molecules. I mean, messenger RNA. So, and especially the messenger RNA is produced completely in a genetic lab. So it's eggs. I'm sorry. There was some discussion within the Catholic Church about early in the production of this adenovirus that is the vector for the Johnson & Johnson. The tissue medium and tissue culture was developed from a placenta from I think an abortion. So I don't want to spread misinformation. it was really distantly related. But even the Catholic Church that is very sensitive to that has actually endorsed the vaccine. And of course, the Pope Francis has called the vaccine basically receiving it a moral imperative for everyone to receive the vaccine. So.
Thank you. Let's see, let me keep going here. Oh, I have another question. So if I am a student who is in good health, eats well, works out, and I'm wondering, can you help us understand why it's important for young, healthy college students to still get vaccinated, even if they're in good health and maybe don't have a number of risk factors?
Yeah, I was one of those. I was young and healthy, and I played football and ran track in college myself. The thing is, it's great to be young and healthy, and part of that is the denial that and that sense of invulnerability when you're young and healthy. But this virus does infect younger, healthier people, and we've seen that. And in fact, there's a clear-cut shift to the younger population with this Delta variant, and it may be because and most likely a big part of it is we've vaccinated the elderly and the infirmed. So, but the fact is we're seeing significant cases within the young population, and that's from age 18 through 40. So to me, that's young, 40. But and so we're seeing it, and we're seeing not only hospitalizations and deaths, but we're also seeing significant morbidity from this long COVID syndrome in younger people. So, and the last is your sense of societal responsibility. We're all in this, and we hopefully, if you're a college student, you've got the social awareness to see the impact of this pandemic on our society, socially, educationally, economically, to our schools. And we all have hopefully a sense of responsibility to do what's necessary to get this virus under control. And if for no other reason than that, I would appeal to you to get that vaccine. So.
Thank you. So here's another question. Can you discuss the difference between innate and adapted immune responses and how a natural COVID infection can induce less immune memory than a vaccination?
Okay, it's a compound question. So
Okay.
let's take the first part. I'm a visual, so I'm not seeing the visuals. So
Okay.
the difference between innate
And adapted immune responses?
Okay, well, innate is basically what you're born with and what's natural to you. And when it comes to a new novel virus, there's no innate immunity, and we've seen that effect. When the explorers first landed in the Hawaiian Islands, and there's no innate immunity to the flu, and the flu basically produced massive infection and mortality within the islanders. So that that's the danger of a new virus. That's why it was called the novel coronavirus. That there's very little innate immunity to this. So acquired is you can acquire it from catching it and overcoming it, or getting a vaccine. So that's the difference between that. What's the next part of the question?
The next part is how can a natural COVID infection induce less immune memory than a vaccination?
Well, it's partially because of variability of response. So someone may have less of a viral load, and so basically have less of an antigenic challenge, and so they may have caught it. And we do know, even with pre-Delta, that up to 25% of those people who tested positive, who had COVID, basically were asymptomatic. So these people had, and that's the argument for masks too. It allows you just to have a small inoculum, a small dose, and that's easily overcome. So, but the problem is if you easily overcome a viral infection, the amount of your immune response and the strength of it is much less than if you had a significant viral load. So you have to walk that line. If you have a severe viral load, then you get massively sick, of course. If you have a small, tiny viral load, you can develop natural immunity, or it's not really innate, but it's natural. But it may be just a small, tiny immune response compared to what the consistent immune response that the injection and the vaccination produces. So.
Great, thank you. Hopefully that answered the person's question. I don't think I fully understood the question, but I think you did, which is what matters. And hopefully the person understood your response. So I appreciate you making the effort. So let's see, I'm looking here. It seems like a lot of the questions that are left are very campus specific. I do want to just remind folks really quickly that many of your questions have been answered. I'm looking at the Q&A right now. More than 50 questions have been responded to in writing that again are very campus specific. But with that, I'm going to go ahead and give the floor for a moment to some members of our campus repopulation task force, just to make sure that they're kind of reiterating a few essential pieces of information that everyone should ideally walk away from today's session with. So Jenny Sorensen, let me go ahead and give you the floor.
Thanks, Paz. I really appreciate it. And I really appreciate all the great questions that we received. You put my typing skills to the test on responding to those. So I hope you'll forgive any spelling errors. But I wanted to encourage everyone, and I put that in the responses to many of the questions. Many of your questions have been answered and are available. Answers to a lot of questions and more are available on the Return of the Pack website. You can find how to get sign up for an appointment for either testing or vaccination. You can find out and link to the policies around vaccination. There's just a lot of information available regarding daily health screens and the links to daily health screens. So I would just encourage you to visit that if you haven't already. And we're adding to that daily. So please continue asking your questions. The task force is really working to try and have as much information available to the campus community as possible. The other thing that you can find at the Return of the Pack site is our weekly cases and the location of where those cases have happened, as well as our vaccination percentage. So how many people have told us that they are actually vaccinated. And so student numbers will be coming up soon. Right now, I believe it still just shows the faculty and staff vaccinations. So really encourage everybody to visit the Return of the Pack.
Great, thank you. Thanks so much, Jenny, for that information. Anyone else from the Repopulation Task Force that'd like to add anything that wasn't already said, or respond just to the group with any of the other questions? I know there were a lot of questions related to daily health screen and some of those other pieces. Lenise, do you want to just hit on that really quickly, just in terms of the daily health screen, or Jenny, anyone, just in terms of I know that I saw the question come through several times about, do you do it the day of, do you do it the day before, like when is the ideal time to do the daily health screen? So I don't know if you all want to just kind of share that really quickly so everyone hears it.
Sure. So the daily health screen should be done the day that you're planning to come to campus. And so it's now a new part of my morning coffee routine, but I would encourage you to fill that out. You can do it on your phone or on your computer. It's in the My Coyote app. And you will be told whether you're permitted to come or not. If, somebody I think had a question about, well, I have a headache and I know it's not COVID related, there is follow-up to that. So even though a headache might be a COVID symptom and so might initially exclude you from campus, there is follow-up from risk management and the disease response team regarding those that have been denied access to campus, so that we can find out more information and then work with folks on whether or not they need to be tested or what their next steps are. So would just really encourage folks to fill out that daily health screen. We also use that information to help if we do have to make a notification if there's a case on campus. So it does ask you, what buildings are you planning to visit? Now, that's not the only way that we do that kind of notification, but it's one tool that we can use. So it really is important for you to provide us information and be as complete in your daily health screen as you can.
Great, thank you. Appreciate that. Let's see. I found a question for Dr. Sakeda. I have a couple more here that I realized I can kind of missed. So I know we've got a few more minutes here. So again, my effort is to try to get through as many of these as we can. Some of them were repeats, so I'm not going to re-ask those same ones. But I guess this was in reference to, I think, one of your slides. So I wanted to make sure that we went over it. The question basically says that one of your slides said that people should not be vaccinated if they had a recent exposure to COVID-19. So the question is, why is that?
Yeah, that actually, I'm sorry, I should probably take that out. But part of that was in the part of the direction for people to go to vaccination centers, and we didn't want people with active COVID infecting others while they were waiting in line. And the other part that has confused things in the past was when we first rolled out the vaccine. We just didn't have enough. And so we did give some credence to the fact that if people had it recently, they probably are a little bit more protected than unvaccinated. So we said, people, if you've had it recently, don't come right now. And you're probably seeing that 90 days. And that's when we figured they were safe for 90 days at least if they had the vaccine. And so that's the reason. There's having had it shouldn't prevent you from getting it. So.
Getting the vaccine. Okay, great. Thank you. So another question was, what effects can COVID-19 have on the brain, heart, and lungs? And I haven't heard about the question is, I haven't heard about the long-term effects. Can you say a little bit more about that?
Yeah, well, I'm glad that person asked it. And if we should have a whole nother section on how COVID affects, the body. But COVID, it was amazing because we discovered, as we were discovering new things about this disease, and I was an ER doc and a critical care doc. So we started seeing this. We saw the test for clotting was just sky high. And we said, there's got to be some kind of clotting phenomenon going on. And we found that in the small capillaries of the brain, of the heart, of the kidneys, there were blood clots just all the way through it. So a big part of, and it was producing strokes, heart attacks, kidney failure. And so when you look specifically at people who have even the long COVID syndrome, which basically, your brain's in a fog, and you basically don't feel good. You have aches and pains. It's not unlike fibromyalgia in many ways. They've done PET scans and looked at, and there's significant microscopic effects on the brain, and this is actually reproducible. So it does affect the brain and the heart and the kidneys and the muscles as well. So and that's the danger. No one wants to catch mono, but this is like a long mono. I mean, this is like 6 to 9, 10 months of this, and we still some of it might be permanent. Some people just have they never get their taste back or their smell back as well. So if you want to take the chance or the risk, you run that risk, and that being young and healthy doesn't protect you from that at all.
Thank you. I appreciate you sharing that. It's good information. So this is actually, I think, a follow-up to the question about the booster. So I know you explained that, that really just the immune compromised folks are the folks that should potentially be taking the booster now. But for anyone else, what is your thinking, or just based on what you know in terms of time frame for everyone else who may not be immune compromised to take what would make sense for them in terms of getting their booster shots?
Yeah, well, if you've all heard in the news this morning, the Biden administration was predicting that by the end of the year, we're going to have that third boost. That's not from San Bernardino County, and it's not from California Department of Public Health, but and those are the national scientists, basically. So I would expect probably a third dose boost becoming available probably by the end of the year. And at this point, we know it's safe, and as long as we've got enough vaccine, I certainly wouldn't hold that back at all. I might be the first in line. So,
thank you. So, this is actually kind of I think, again, another follow-up question to something that you responded to earlier. So they were making reference to the VA ERS system that has, I think, some statistics regarding reports of adverse events to the vaccine, and that they emphasized in their question that these are unverified reports. And they basically said, can you recommend a verified site that folks can visit to see actual data about the adverse events related to the vaccine?
Well, actually, there are multiple. If you look at, I would go to the Lit COVID, which is basically a compilation of all the studies that have done with regard to COVID, and it's actually produced by Elsevier, which basically produces many of the medical journals. The New England Journal of Medicine, which is probably the most respected medical journal in the world, actually they have an open access forum as well, and you're more than welcome. Anything that appears in the New England Journal is extremely edited and reliable. So looking at raw data like theirs, that really isn't controlled and evaluated, it can be very misleading. So check those out, and JAMA actually has a free open access forum with regard to COVID as well. So,
can you tell us again, what was that for? You said Lit COVID. Is it? Do you want to type it in the chat, or you can just tell it to me and I'll type it in, but just so that folks know where they can go to look for that information, because I think that's a really helpful resource, particularly in an academic environment, right?
Yeah.
Going and looking for reliable research is what we should be doing. So I think if folks can go there and look for that information, that'd be helpful.
Yeah, I don't know the exact. I'll look it up because it's on one of my favorites, and I click on it every day just to see anything new. So
okay, awesome. That would be really helpful.
Mm-hmm.
Let's see. Okay, thank you. Let's see. I'm trying to just see what else in here. Okay, so here. Oh, I'm sorry. Yep, go ahead.
No, I was going to ask a question, or I just wanted to answer. There's some questions about where you can get vaccinated. There are pop-up events happening today and tomorrow at the campus tours that are happening on campus. They are offering the 1-dose Johnson & Johnson vaccine without an appointment. You can just show up. They will be at the flagpole kind of out in front of campus. And so we're also going to be having on-campus vaccination next week for the start of school as well. The actual location, keep an eye out. It will either be in Yasada or at the Ask Me booths. But certainly there are vaccination opportunities on campus for free, no appointment required.
Great, thank you for sharing that. So more places to get the vaccine on campus. Looking here at the time, we've got just a couple minutes left. Again, another question here. Let's see, can Dr. Sequeira talk about what Dr. Malone has found in regards to the mRNA and the spike proteins that the vaccines are said to be harmful? I'm not sure if you know what that they're referencing there.
Actually, I don't know the study.
Okay.
It hasn't made it through to the peer-reviewed journals, but if someone.
Okay. Let's see. I think that is most of them that we didn't already get to that are not just the campus-specific questions. Oh, there is a question in the chat that maybe folks on the Repopulation Task Force can respond to, which is just if we're offering the vaccinations at Palm Desert as well, which I know we are. So I just wanted to make sure that folks got that information.
Yeah, so the testing group will be doing testing at the Student Health Center at the Palm Desert campus, and they will also be offering vaccination there as well.
Great, thank you, appreciate that. Let's see, so I think that is going to cover it for today. I know I'm seeing here almost 70 questions have been responded to in the Q&A, so I do really want to thank everyone that has been here today to respond. Dr. Sequeira, thank you as always for all of the wonderful information and all of your efforts to really, I think, respond to some very specific questions. So I appreciate you taking the time to be here with us and educate our campus community. And of course, to all the members of the Repopulation Task Force who, as Jenny mentioned, we're vigorously typing away throughout the session, trying to get all those answers in regarding campus-specific questions. As was already mentioned, I do really want to remind folks to please make sure to look at the Return to the Pack website. That is probably your best resource for reliable information. Please complete your self-certification, vaccinated or not. We need that from everyone. So you do want to get that self-certification in your My Coyote portal completed ASAP. Obviously, we want you to get vaccinated. We're providing you with resources on all the different places you can go in the local area as well as on campus to get that done. So as Dr. Cicada mentioned, I think multiple times, there is no shortage of vaccines at this point. So they're very readily available. So you can definitely take advantage of that. I do see a question just to the panelists about vaccination on campus with no appointment. Is that correct to our panelists here? Can folks, when folks want to do the vaccinations here on campus, are they required to do an appointment or can they just walk in?
Yes, right now for the pop-up events that we're hosting, no appointment is necessary. You can just walk in. Obviously, if you have an appointment, it may be faster, but either way, we want to make it as convenient as possible for you to get vaccinated.
Great, thank you. You know, I did see one other question, and I thought we had responded to it, but maybe we didn't, which is just how soon vaccination will be available to children 6 to 12 years old. I know we talked about the 13-year-old, but I don't know if there's a time frame for that age group.
Yeah, not soon enough. The problem is that, you know, the more specific the group, the harder it is to get into the hundreds of thousands of vaccinations to prove safety. So we're waiting, and we're told, you know, maybe by the end of summer, but it can be none too soon. You know, so far we from the study sources that we've seen, it looks to be very safe. But again, it's not gonna be released until it's proven to be safe. So take the delay as basically an underlining of the safety process.
Wonderful, thank you. And thank you again. I think we're at just about at time. So again, I want to thank you everyone for joining us today to hear the information. Dr. Cicada, again, thank you for being with us and helping to provide reliable information to our campus community. And again, thank you to the Repopulation Task Force for your efforts to be here and respond to all the questions related to the campus. So thank you again, everyone. Stay safe and healthy out there. Get vaccinated, do your self-certification, and we'll see you all soon on campus. Take care, everybody. Thanks so much.
Bye-bye.
Bye-bye.